Hello, my name is Dr. Martin Gleave. I'm a professor and chair at the Department of Urologic Sciences at the University of British Columbia and director of the Vancouver Prostate Centre. And I'd like to thank you for the opportunity of being able to share with you a perspective on how advances in biology and technology are helping us to define and target the adaptive molecular landscape of metastatic advanced prostate cancer. And in doing so, I'd like to focus on reviewing mechanisms of treatment resistance in CRPC, move on to examples of advances in novel and combination therapies in CRPC, really in a framework of precision oncology, and try to keep this and point out the relevance in particular for urologists. My conflicts of interest are outlined here. So the treatment landscape for advanced prostate cancer has evolved significantly over the past couple of decades. AR pathway inhibitors like ARPI and ENZA have helped redefine the prostate cancer landscape, moving upstream to metastatic castrate-sensitive disease. Taxane chemotherapies have been displaced back to second and third line prostate cancer, but have also moved upstream in combination with ADT and castrate-sensitive prostate cancer. And these are all available along this spectrum. As cancers evolve and become resistant, AR genomic and intratumoral steroidogenesis continue to support reactivation in the majority of recurrent tumors. Moving docetaxel and AR pathway inhibitors earlier in combination with ADT has improved outcomes, but really combining and sequencing these have not significantly prolonged survival, likely due to cross resistance. And so what we are ending up with as cancers evolve is this segmented population of AR-driven and AR non-driven cancers, which can include DNA repair deficient and AR indifferent or quiescent cancers. And we really need to develop biomarkers that allow us to choose AR pathway inhibitors, to choose an AR pathway inhibitor versus docetaxel and castrate-sensitive disease, to define the optimal sequencing of AR pathway inhibitors in first and second line, and to help with the selection of targeted or immune therapies in the appropriate patient. And finally, of course, we want to continue to define and detect emergent treatment resistance. And all these are part of the promise of precision oncology, which is about individualizing cancer care based upon a patient's tumor-specific alterations. But this, of course, has challenges as well, in that we've got to be able to identify, at least currently, genomic or DNA alterations associated with durable response to standard or off-label treatment, but also that have predictive capabilities of matching the right drug to the right patient tumor genotype. And over the past 5 years now, the work by the two Stand Up to Cancer Dream teams, the international as well as the Stand Up to Cancer West Coast Dream team, has helped to define the genomic landscape of metastatic tissue biopsy CRPC. And broadly based, these are shown here in the AR, PI3K, cell cycle, DNA repair, and lineage plasticity subgroups. They can be bundled into each of these as far as genomic alterations, and the most common being AR at 50 to 60%. But what this, of course, does not capture is the adaptive pathways that are activated in response to treatment stress, which can be in the areas of stress, metabolism, and energetics. So not everything that genomics and the biomarkers can quantitate is capturable at the present time. In addition, a limitation of precision oncology is the acquisition of tissue. And there are real limitations to metastatic tissue biopsy, illustrated by this metastatic bone scan here, that there are multiple biopsies, and which one of these are we going to sample? And does that biopsy represent the entire disease from a genomic point of view. And so while interpatient heterogeneity underpins the basis for precision oncology, inter-tumor heterogeneity complicates profiling of single biopsies, and hence we need a liquid biopsy to help capture this intertumoral heterogeneity, but also make it more feasible to monitor genomic evolution over time while on therapy. And work at our institution with Kim Chi and Alex Wyatt has helped to develop circulating tumor DNA assays that help to characterize a prostate cancer genome from plasma. And like from the tissue biopsies, we're able to detect in the metastatic CRPC population AR mutations or amplifications in about 50%. In addition, there are alterations seen in other important groups, for example, BRCA, RB1, and PTEN. They're captured in the same frequency as detected in the tissue biopsy series. These assays were compared directly to the tissue biopsies from the Standard of Cancer West Coast Dream Team, and we reported in the JNCI that circulating tumor DNA surveys this interpatient heterogeneity better than the biopsy of a single metastatic site, helping to set the stage for this to play a role in as a alternative to a tissue biopsy in following or tracking the evolving cancer genome. But we also wanted to determine whether or not this circulating tumor DNA could play a role as a prognostic or predictive marker. And in this regard, we led a randomized phase 2 trial led by Kim Chi in Vancouver, randomizing patients with metastatic CRPC to either ABI plus prednisone or ENZA. These were previously untreated. Upon progression, they were then crossed over to the opposite regimen and followed until progression and death. And at each site, we were able to get a time frame, baseline crossover, and then second crossover, we were able to get plasma for circulating tumor DNA assays to help to characterize effects on prognosis. In terms of the first line setting, time to first line progression, there was no difference between the ABI or ENZA group. What we were particularly interested in, though, were those extreme responders, those patients who had primary resistance or progression as best response, versus those that actually had a very good delay in time to progression. And the reports from the ctDNA were reported in cancer discovery, identifying alterations in BRCA, P53, PI3K, and AR amplification as being prognostic for rapid time to progression. So again, alterations in genomic markers are prognostic for a shorter time to an AR pathway inhibitor. More recently, and this is now in press in Lancet Oncology, time from first-line therapy to second-line progression has been reported. And interestingly, those patients who were on ABI followed by ENZA did better than those who were on ENZA followed by ABI in terms of both PSA progression as well as a trend towards overall survival. It's certainly underpowered for survival, but hazard ratio was reasonable. So there was this separation of curves suggesting that ABI versus ENZA, ABI followed by ENZA outperformed the alternative. And similarly, in the bottom graphs, you can see differences in PSA response rates. Again, this would suggest that there were different mechanisms of resistance to ABI versus ENZA that may enabled some patients progressing on ABI to then subsequently respond to ENZA. And again, this requires evaluation at the genomic level. So this is just a heat map of some of the alterations detected in patients on this trial. And as is seen in tissue biopsies, there were alterations in some genes that were potentially matched to different drugs that are ultimately not approved in cancer, but may be used in an off-label precision oncology type of an approach. But the alterations that were most of interest were those with DNA repair or BRCA, as well as AR alterations. And so DNA repair alterations have become more apparent in prostate, as they are in ovary and breast. More recently, about 20% of CRPC patients have been identified to have alterations in DNA repair genes like BRCA, ATM, and FANCA. There's a poor prognosis of prostate cancer for germline carriers, and there's a resistance to first-line AR pathway inhibitors for patients with BRCA alterations. These also tend to predict for PARP inhibitor response, as well as platinum chemotherapy. And this is work out of Yohan de Bono's group, published in the New England Journal, showing that patients who had alterations in DNA repair were more likely to respond to a PARP inhibitor in terms of delaying time to progression compared to those who did not have a DNA repair alteration. So again, PARP inhibitor response was related to patients who had an alteration in a DNA repair gene. And more recently, and this is going to be presented at ESMO later or in the fall of this year, the PROfound phase 3 randomized trial of olaparib in metastatic CRPC has made a press release reporting that it's met its primary endpoint, where men with metastatic CRPC with BRCA or ATM mutations had a delay in progression when treated with olaparib versus an AR pathway inhibitor. And this will be read out soon and will likely lead, if significant, to a change in practice. Now, the other alteration of significance are treatment-induced changes in the androgen receptor, which represent the most common alteration. And again, all the drugs that we use, whether it's ADT, with or without an AR antagonist, target this ligand binding domain. And while no prostate cancers have alterations in the AR when untreated, the moment we treat them with ADT, they develop alterations in the ligand binding domain, which include mutations that lead to promiscuity, splice variants where the ligand binding domain is lost and the AR is constitutively active. And you can also have increased copy numbers called AR amplification, which is associated with increased AR activity. So being able to detect this is prognostically significant in terms of response to an AR pathway inhibitor. And this has been reported by the Hopkins group, that if you have an ARV7 expression in circulating tumor cells, then you are much less likely to have a PSA response compared to either ABI or ENZA compared to if you are a V7 negative. And this is not seen with docetaxel. So if you're V7 positive, you're more likely to respond to docetaxel compared to an AR pathway inhibitor. In addition, if you are AR amplified, and this is work by our group in Vancouver, and as well as the group, Gerta Dard's group in the UK, that overexpression of the AR is associated with a shorter response to an AR pathway inhibitor. Again, negative prognostic significance. But in addition, what this trial using ctDNA has showed is that when you look at the ligand binding domain under the selective pressures of androgen deprivation and an AR pathway inhibitor, you get an evolution or acquired or new alterations that in the ligand binding domain. For example, the 702 mutation can confer response to agonism to prednisone. The 742 mutation to bicalutamide, a 878 mutation to flutamide, and so on. So these are agonizing mutations that emerge that can turn a brake into an accelerator. And I'll just give you an example of this with this patient, an illustrative example. Patient relatively young, diagnosed with metastatic prostate cancer, initially treated with a charted regimen, ADT plus bicalutamide plus docetaxel, had a reasonable response but of short duration, about 6 months after treatment, progressed with increasing bone mets, skin mets, and a rising PSA. We did his genomics gene sequencing of his tissue biopsy at diagnosis, where no alterations in the AR were detected. But after 6 months, the plasma DNA done at this time detected 2 alterations in the 742 locus, which is a bicalutamide agonizing alteration. By changing the configuration of the ligand binding domain, it makes the bicalutamide become an agonist instead of an antagonist. Enzalutamide remains antagonistic, but this alteration also causes DHTB to be a superagonist. So based upon this, we actually treat him with combined ABI and ENZA. He actually had an excellent response for close to 2 years, compared to only 6 months first line. His circulating tumor DNA completely disappeared during this response. But after 2 years, his PSA began to rise. And even before he developed any symptoms or radiographic progression, his plasma DNA began to show a development of an aggressive phenotype. All breaks were lost. He lost all his key tumor suppressors, P10, RB, and P53, and he gained an accelerator. The AR became amplified, 30 copies of his AR. And 6 months after this, he died of his disease. So again, this is illustrative how the AR genome, the prostate cancer genome, can evolve over time under the selective pressures of treatment. And as we get more drugs to target some of these, obviously we may be able to control it. And so there is a need for novel agents to target AR amplification and reactivation, and a number are under development targeting the N-terminal or DNA binding domain by AR chaperone inhibitors or through AR degrading approaches. These are all in the preclinical space at the present time. I'll just finish off by pointing out another key limitation to precision oncology. Despite all its promise, we have to recognize that the long tail of the mutation curve plus the low availability of off-label drugs makes this very expensive, and I'll come back to that. But in addition, we know that DNA insufficiently captures Darwinism. We share 95% of our genome with chimpanzees, but we look very different. In addition, the same genome here and here or here, it can create very different phenotypes without any alteration in DNA at all. So many things downstream of DNA sequence can confer significant changes to biology, and we have to capture more of that in addition to just DNA sequencing. And as an illustration of this Moscato trial from France randomized patients with advanced cancers. There's any advanced cancer. They were sequenced, and then they went on to have a drug based upon that sequence. And of 100 patients enrolled, for every 100 patients, half had a potential alteration that was druggable. Of that 50% with an actionable alteration, only 25% could get a drug for it. And of that 25%, only 7% actually had a deemed benefit. So again, very small proportion of patients with a precision medicine oncology approach is having a deemed benefit. And a similar result was published in JAMA out of the North American population just last year. So we have to improve upon this rather inefficient beginning, but it's still promising as long as we build upon these limitations. And that includes an understanding of the biology, the other mechanisms that are involved in treatment resistance, aside from AR alterations or loss of tumor suppressors. This includes crosstalk activation with growth factor signaling, the activation of stress response pathways that help cancer cells survive the stress of treatment, shifts in energetic reprogramming of cancer cells as we treat them with our anti-cancer agents. And all these are exploitable through co-targeting and with preclinical proof of principle and some clinical proof of concept as well. But I want to just finish with an example of how cancers can evolve through concepts involving lineage plasticity, which involves reactivation through a stem-like intermediary into alternative lineages like EMT or neuroendocrine cancer. And so neuroendocrine prostate cancer is a subtype of CRPC associated with poor survival. It evolves through divergent clonal evolution through work by Misha Beltran and her group at Cornell. It's a rapidly progressive cancer with low PSA, low AR activity, and visceral mets, highly mitotic and glycolytic. In our West Coast DREAM team studies, we were able to detect this transition through tissue biopsies and arrays, where you could actually see a distinct expression profile as an adeno went from a intermediate atypical through to a small cell or treatment-induced neuroendocrine, which after AR pathway inhibition is now in about the 15% range. So these cancers evolve from a CRPC adeno as a mechanism of resistance. They share the same genomic alterations as CRPC. They acquire new genomic alterations, for example, RB, P53 loss, and others. Adeno markers are lost, so they are PSMA PET negative, but they are FDG PET positive because they become more glycolytic, and they express markers of neuroendocrine lineage. And as a model of this, we were fortunate enough to be able to grow a cancer out of a patient with a Gleason 9 adenocarcinoma. His tumor was grown in a mouse as a patient-derived xenograft, and when it grew in a mouse, it produced PSA as tumor volume increased. When the mouse was castrated, the tumor regressed, went into remission, and then recurred about 4 months later. But this time it recurred as a PSA negative, pure neuroendocrine. The gene sequence, DNA sequence here, was identical to here, and yet the phenotype was very different. No PSA here, PSA here. And when we do expression profiling, all the adeno markers are lost, and we gained neuroendocrine markers as well as stem markers and epigenetic markers as the neuroendocrine tumor emerged. Again, no DNA alterations, illustrating the importance of things other than DNA in driving this trans-differentiation event. Interestingly, the patient himself followed a similar path. After surgery, his PSA went to 0, recurred with rising PSA and bone mets. He was treated with chemohormonal therapy, had a complete remission, but then 2 to 3 years later recurred with a negative PSA and bone mets. The bone mets were biopsied, and they were a treatment-induced neuroendocrine cancer, and the patient ended up dying downstream of platinum. But again, this shows how a patient xenograft or avatar may, in a precision oncology sense, predict for how a patient may evolve over time in real life. The important, this model and others by number of groups are now starting to illustrate the complexity of treatment resistance through lineage plasticity. Involves both an interplay of both genomics, epigenomics, splicing alterations, selective or transcription, as well as selective translation that ultimately allows cancer cells under the selective pressures of treatment to evolve from an adeno through and into a treatment-induced or lineage infidelity type of state, again from a from a mechanistic point of view, these are now several important targets that are being drugged to help to potentially treat this, including EZH2 inhibitors, which are in the clinic now. So I'll just summarize by saying that defining mechanisms of CRPC are yielding new targets and drugs. 7 have been shown to prolong survival, 9 including combinations. Molecular subclassification is key to this stratification. We need to better identify those who do badly with first-line AR pathway inhibitors, which patients may benefit, which 15 to 20% may benefit from sequencing ARPI and ENZA. And plasma ctDNA assays enable a real-time monitoring of treatment-induced mutational adaptations in this state, will be key to precision oncology approaches going forward. They'll also be important as companion diagnostics for novel drugs targeting the AR outside of the ligand binding domain, and through co-targeting strategies involving each of these important pathways that I highlighted as being drivers of resistance. So as urologists, we have to recognize that many of these treatments initially developed in the advanced metastatic setting are moving upstage into first-line combination regimens, and now even being tested as part of neoadjuvant regimens prior to surgery. And as such, we have to remember our history, evolving as applied anatomists and applied pathophysiologists last century, to now using computer-aided imaging with CAT scans, and now functional imaging with PET scans. These will be combined as we digitalize biology further with genomic and expression profiling data, as we increasingly understand the complexity of this disease and are better able to segment it and treat it going forward. I'd like to thank and acknowledge the many people who help contribute to this work at our center in Vancouver, at UBC and the Vancouver Prostate Centre. The long list of principal investigators are outlined here, but especially noting the seminal work of Alex Wyatt and his ctDNA assays, Art Cherkasov through his computer-augmented drug design core, and Kim Chi, our medical oncology partner and colleague, the many fellows and postdocs, as well as our collaborators through the West Coast Dream Team, through the Pacific Northwest SPORE grants. I'd like to thank you for your attention.